This HIV update provides an overview of the management of the antiretroviral naive patient, presented by Dr. Jamie Morano. The activity planners do not have any financial relationships with commercial entities to disclose. Dr. Morano has financial relationships with the following commercial entities to disclose: Grant Research Support, Pfizer Inc., Grants for Learning and Change, and Vaccine Link. Dr. Morano will not discuss off-label use of investigational products during this presentation. This slide set has been peer-reviewed to ensure that there are no conflicts of interest represented in the presentation. Upon completion of this program, participants will be able to recognize when to start antiretroviral therapy, ART, according to the most recent Department of Health and Human Services DHHS guidelines. Explain how to choose initial ART based on patient profile. Discuss potential side effects from ART. Describe ART initiation when the patient has viral resistance. And identify recommended ART with hepatitis B coinfection. The following statements relate to continuing medical education and continuing education. This session is approved for up to 1 hour of CE-CME. This enduring activity has been planned and implemented in accordance with the essential areas and policies of the Accreditation Council for Continuing Medical Education through the joint sponsorship of the Florida AHEC Network and the Florida Caribbean AIDS Education and Training Center. In order to receive CE or CME credit, you must complete an evaluation survey, which includes a request for CE-CME. The evaluation survey link will be provided at the end of the video. When asked in the evaluation survey, indicate that CE-CME is requested. You will then be directed to a survey that must be completed for our CE-CME provider. The CE-CME provider survey will include a post-test assessment. You must achieve at least a 70% in order to receive CE or CME. Participants will be able to print or save their certificates after successful completion of the post-assessment. Please note, if you received CE or CME credit for the live webinar that took place on December 9th, 2014, you are not eligible to receive CE or CME credit for this on-demand module.
It's my pleasure to introduce Dr. Jamie Morano, who is a faculty member of the Florida Caribbean AETC and assistant professor in the Division of Infectious Diseases and International Medicine at the University of South Florida Morsani College of Medicine. Trained in NIH-funded research at Yale University and currently co-principal investigator on the Vaccine Link grant, she has experience with HIV and hepatitis C in marginalized immigrant and incarcerated populations, and currently serves as HIV attending at the Hillsborough County Health Department Specialty Care Clinic, as well as an infectious disease consultant for the immunocompromised at Moffitt Cancer Center. She holds an MPH degree in epidemiology and biostatistics from Harvard University and a politics East Asian studies degree from Princeton University. And without further ado, I would like to turn things over to Dr. Morano.
Wonderful. Thank you so much, Dr. Orek. It's a pleasure to be with all of you today. I'd like to start by welcoming you and making sure that it's all working here. Yep, great. We'd like to go over a couple of objectives today. I noticed many of you are coming from health departments, so I'm going to tailor my talk a little bit towards that. But today we'd like to recognize when to start antiretroviral therapy according to the most recent Department of Health and Human Services guidelines. Secondly, we'd like to explain how to choose your initial IRT based on patient profile. For the third, we'd like to discuss potential side effects from any antiretroviral therapy. Next, we'll describe ART initiation when the patient has viral resistance. And lastly, we'll identify a recommended ART with hepatitis B co-infection. So why is ART important? I know many of you have learned a lot about antiretroviral treatment, have seen it working in action, but why is it really important to get everyone on therapy? Well, there's a couple of important points. As you see, Florida has one of the highest rates of new HIV infection. You can see Georgia has a high rate, Washington, D.C. has a high rate, but we are still higher than states with greater populations than we are. So we're higher than California and New York, which is concerning. So we have a lot of work to do in terms of getting people in Florida on therapy. So I wanted to talk a little bit why it's important to start ART with someone who has tested HIV positive. I'd like to highlight on this slide that minority males are most affected. So those of you working with case management, medical case work, your work is so important because we're trying to get folks linked to care, folks on insurance, get people tested and to get access to medication. You'll see a disproportionate effect in our minority populations. I'd also like to highlight the differences between genders. In our male population, we have male-to-male, a lot of male-to-male sexual contact transmission. However, in our female population, we have more heterosexual contact. So again, for your outreach and clinical work, just be aware that many of the transmission modes are different between the genders. So in terms of tailoring your message to your patient population, sometimes it's helpful to understand their background socioeconomically in terms of tailoring any treatment and outreach programs. Now, I'd like to highlight HIV prevalence by selected states, and this is directly from the Florida Department of Health slide set, but I wanted to show just a couple of important things. Florida is a little bit different than the rest of the country in terms of the HIV epidemic. You'll see that we have a large MSM population that's men who have sex with men who may not be reached by our traditional methods of outreach. We also have less, thank goodness, less intravenous drug use in Florida. So a lot of the messaging that you'll see for outreach in the Northeast may not be as helpful in Florida outreach, where our epidemic is a little bit different in terms of population. Florida itself, I know everybody is working hard at treating HIV, but we still have a lot of work to go. As you know, we're the fourth largest state in terms of population with 19.3 million people. We still have the top 3 prevalences of HIV in the state, and we also have one of the top 3 incidences. So that means that we not only are top 3 in the new HIV infections, but we thankfully are sustaining folks on medications, but we're also having a larger proportion of our population with HIV, which has, as you can imagine, huge consequences in terms of making sure these folks stay on medications and that we keep them healthy throughout their lifetime. I'd like to go over what happens without ART. I've gotten some questions before about, why do we start antiretroviral therapy if someone's not ready or if someone's not willing to be adherent? Well, I wanted to just remind everybody about the rapid pace that the virus really takes off without any medication. You'll see that with primary infection in the blue, basically what happens is the CD4 count takes a hit over a couple of weeks and really then starts to take more of a slow decline. And you'll also see that your viral load, the viral load of an affected patient will also increase. So even though someone may not be showing symptoms, the virus is already in the body and establishing latency, and as we'll see a little bit later, is already causing problems to the patient. So doing our best to really try to get folks on therapy is a good idea. I wanted to highlight this. HIV as a virus evades the immune system. So this is different than hepatitis C, right? Hepatitis C we can actually eradicate because it does not incorporate itself into the body. Hepatitis B, we can do a good job treating it, but it still stays a little bit behind. But HIV, absolutely, we cannot clear it right now from the body. It has something called latency. And essentially when HIV is not treated, it continues to attack the T cells and B cells, the immune system of the body. So it's very difficult to, stop the progression of viral disease without antiretroviral therapy. HIV causes inflammation, it causes weakened immune system, and it causes weakness of CD4 counts. And these actually lead to premature morbidity and mortality in our HIV-positive populations. I think many of us know that ART does prevent opportunistic infections. The data is pretty clear at this point, especially viral illnesses, to a lesser extent fungal infections, but this is a nice study done a couple of years ago that really showed that ART not only prolongs life, but it also prevents secondary infections. And the good news is that folks now on ART can actually have a longer life. This is from the NA Accord study, and this is showing how we really are increasing the lifespan with these life-saving medications. I wanted to show you this cascade. Many of you are probably familiar with it. With those who it's new, this is the CDC Cascade published in 2011, and it's really been the kind of landmark motto, if you will, for getting people into care. You can see to the left of your screen of about 1.2 million people HIV infected, we only diagnose a fraction of them, and of those diagnosed, we only link a fraction of those to care. And as you can see, only about 480,000 are retained. That means that they're participating in regular appointments. You can see of 1.2 million, we're only really retaining less than half of those folks. The other folks are progressing with disease and having transmitted infections and needing to come into care. And you can see that of the total, we're only suppressing about 328,000. So we have the medications. The challenge is getting people to the medications and identifying those folks. So how to start ART? Well, I wanted to go over the guidelines, but I wanted to focus on the updates and what you need to know practically in your work. These are all available online. The government makes these free and available. They're very well written, and just to point out, they are written both in sentence form and they're also condensed in table form. So however you like to process information, there's something there for everyone. Has excellent compendiums on dosing. It's really a wonderful resource. So what is new in 2014? You've heard a lot about guidelines, you've heard a lot about treatment. Well, the game changer was dolutegravir. Dolutegravir is an integrase strand transfer inhibitor, basically a fancy word for saying it basically interrupts HIV from integrating into the genome. Dolutegravir has been an amazing advancement because it's a once daily dosing, and it's an antiretroviral medication that actually is very promising because there's very, very low resistance to it right now. So in your patients who have been in and out of care, this is potentially a life-saving drug for them. And so much so that it was incorporated into 2 of the 4 integrase strand transfer inhibitor regimens. We'll go into more detail, but suffice it to say we now have 4 approved regimens with the INSTI class, which is really great news for our folks with HIV who've had long-standing infections. What also is new in May, because populations were doing so well and the drugs worked so well, if someone is suppressed, has a suppressed HIV viral load greater than 2 years, and their CD4 count is consistently above 300, we can actually, we can actually extend the HIV viral load testing to every 6 months. Which is great. It means that your patient doesn't have to come in as often, and it's less hassle for the patient. And we can also extend CD4 count potentially every 12 months. Now this works clearly in a population set who is very adherent and very on top of their medications. May not work for everyone's patient, but it certainly is possible as the medications are so effective. And this is the verbatim from the guidelines. You can see how it's worded. Also important, in November of 2014, new hepatitis C agents came on board. The very, very good news about this is that we have a NS5B inhibitor called sofosbuvir. Now sofosbuvir is a game changer as well. It has very little reaction, in fact no reaction to the ARTs. It only has a reaction to one that we don't use. So that is wonderful. The ones that we use in common practice it does not react with. So that is really good to keep. And then ledipsivir and sofosbuvir is really the new combination that we're using now for hepatitis C and folks co-infected with hepatitis C and HIV. Just a word to the wise, the hepatitis C agents you might have heard of in the past boceprevir and telaprevir, we're actually no longer using. These direct antivirals for Hep C had such a large side effect profile and had so many interactions that the new ones came along, and it's no longer the standard of care. So just a heads up, toss away your boceprevir and telaprevir and roll out your ledipasvir and sofosbuvir and also your simepavir. Goals of ART treatment. Certainly we want to reduce HIV-related morbidity, mortality. That's our main goal here. We want to prolong duration and honestly quality of life. I'm sure many of you have seen that folks on ART feel better, they're healthier, they gain weight again. They really can enjoy their interactions with their family and friends. Very, very important. Their immune systems are becoming stronger. And also prevents HIV transmission. So folks who are still engaged in either high-risk behavior will have less chance of progressing and transmitting the infection to others. Recommendations for initiating ART. Take-home messages for everyone. It really should be emphasized for all of your patients. Certainly there are subsets of patients that is more critical than others. Certainly any of your patients who are pregnant, any patients with an AIDS-defining illness, such as dementia or a opportunistic infection, such as pneumocystis pneumonia or cryptococcus meningitis, cryptococcal meningitis, anybody with HIV-associated neuropathy or nephropathy, anybody with co-infection with hepatitis B or C, anyone with a new HIV infection, and then anyone older than 50 years old. Certainly most important to get patients on therapy if they have low CD4 counts. Those are the higher recommendations, A1 and A2. But also if their CD4 count is above 500, we are seeing evidence that helps decrease inflammation and prolong quality of life and also outcomes. So would recommend that as well. So ART to reduce transmission, and this is important also in the perinatal transmission. So suppressing pregnant patients, their viral load is extremely important so we don't continue any mother-to-child transmission chain. Also, patients should be willing to commit to treatment, but with these once-a-day regimens and the low side effect profile, we've been very pleased with adherence, but certainly making sure your patients understand that be taken regularly. So this is just to show you the SMART study. What it showed was that with viral load suppression, not only are we seeing less opportunistic infections, meaning less infections from a weakened immune system, we're actually seeing that we're having less incidences of other diseases, whether that be liver disease, kidney disease, cardiovascular disease. Especially for renal disease, we really see added benefits to ART. So it's not just suppressing the HIV virus and inflammation, it's actually preventing other organ damage of someone who has HIV infection. So something else to bring up with your patients. And also transmission. There was a landmark study, the HPTN-052 treatment as prevention trial, that actually showed 96% reduction in HIV transmission. Unbelievable. So it's really working better than any vaccine out there. So very exciting and definitely a reason to treat. And today we're very lucky, thanks to the very good work of scientists and public health folks and outreach folks. There are very few barriers to antiretroviral therapy today. Antiretroviral therapy is incredibly less toxic today. You remember the days of the 80s and the 90s, people had a lot of side effects. These are a lot less now. We have a lot less drug resistance, not only because we're having people on therapy, but also because we're having new ART medications. We're getting a little more savvy in terms of adherence counseling. We actually have designated folks, you probably have them at your clinic as well, who work with medication adherence and understanding the reasons why folks are having trouble with meds. And we're also very fortunate in Florida to have the ADAP program, the AIDS Drugs Assistance Program, which provides antiretroviral therapy free of charge or at low cost to qualifying populations to make sure everybody is able to take ART. And I would rarely defer ART. You have some elite controllers you might have heard of. These are folks who are genetically lucky, if you will, and the HIV does not progress with them. But this is a very small percentage of the population. We do still offer therapy for those interested, but those are very rare. The next category would be someone with severe mental health issues or personal issues, but arguably we should be proactive with those subsets of populations to overcome those barriers and to get them into care. Not barriers to care, there are studies that demonstrate that folks engaging in intermittent intravenous drug use still can be adherent to ART, certainly an argument to get those folks into care and counseling. But incarceration, we're getting pretty savvy about continuing regimens in the prison setting, and so we're really eliminating these barriers to ART, and I'd encourage you to be creative and also to look at your local resources, because there's a lot of wealth of information and resources out there to help even the most difficult or troubled patient be on ART. So how do you select the initial ART regimen? Many of you are, of course, are experienced in terms of writing ART medications. I wanted to go through this kind of in a holistic form and not just, spew out alphabet soup for you. I want to kind of get you to understand the holistic way of prescribing here. So this is the HIV Virion, and you'll see it has a couple of parts, and this is important because these are where your drugs are acting. The first part of HIV is you have a fusion of the HIV capsule into the host cell. This is important because that's how the HIV docks. It's like a spaceship on a planet, or a space station, if you will. It has to dock into there. And your CD4 receptor and your GP120 on the virion are kind of like that space station docking. And without a good receptor, you can't block. So if you have a drug called a fusion inhibitor, or if people genetically don't have this receptor, the virion cannot block, and we've seen that in some populations. This receptor is a CCR5 or CXCR4, and we'll get to that a little bit, but just know that you have to have the receptor for HIV to dock. So that is important to remember, because if you can block the receptor, you can block the HIV from docking. The second step is that the HIV capsule opens, kind of like a spaceship analogy again, and this capsule comes into the cell. And the interesting thing about the HIV virus is it's a retrovirus. You've probably heard that. Retro means it goes backwards. So instead of your DNA to RNA, it actually goes RNA to DNA. And it's a little bit unusual that way. That's why a lot of these medications we're giving works on the HIV and doesn't cross-react with the human body. So that is where your nucleotide and nucleoside reverse transcript inhibitors will work. We have the non-nukes and the nukes. Those basically interact with this step. The next step you'll see is the integrase inhibitor. The integrase inhibitor, or integrase strand transfer inhibitors, remember we talked about how the HIV virion integrates into the genome, right? Integrates into the human genome. This medication stops the integration of the viral RNA into the host genome. So another mechanism of action. Protease inhibitors, probably the most famous class. These were one of the first to come out. The protease, it basically is an enzyme. It cleaves the protein, so it basically stops the HIV virus from cleaving the proteins to make new virions. And then the last one is maturation inhibitors. So the budding, if you will, or the seeds, if you will, that come from the cell, it stops the maturation. So this is another way of looking at it, and I have to give credit to Dr. Michael Varada at the Yale School of Medicine, who kind of came up with this way of thinking about it. It's a mind map. For those of you who learn better visually, I learn better visually, so this might help. So we have an NRTI, right, a nucleoside or nucleotide reverse transcription inhibitor. The biggest one you've heard of is tenofovir, and I've purposely put in the full name, the abbreviation, and the brand name. I'd encourage all of you to use the generics. The brand names are certainly easy to remember, but the generics are really helpful when you're thinking about guidelines and trying to understand how these work. So you have your tenofovir. and you have your emtricitabine, right, your FTC, also called Emtreva. There's also together, they're called Truvada, and this is your backbone, really, of a lot of your regimens. Remember, tenofovir and emtricitabine, both are nukes, make up a brand name Truvada, and you'll see this written a lot as TDF-FTC. Also to know is abacavir, ABC, also called Xiagen. Abacavir and its partner lamivudine, 3TC or Epivir, make up the brand name Epsicom. So remember, Epsicom, you're combining abacavir and lamivudine. Now, oh, how did it go down? That's okay. Hopefully you can still see this on your screen. The next is zidovudine. Thank you. The zidovudine actually has two abbreviations because it was the earliest drug. It was originally an anti-cancer drug, and it got pulled off the shelf and re-patented as an HIV med. But you'll have zidovudine, that's the original nuke, AZT and ZDV, also called retrovir. That was in the original Combivir. Many of you remember the zidovudine lamivudine combination. And then the other drugs we don't use, so don't get confused by them. You'll see them, thrown about, but we really don't prescribe them anymore. Didanosine, stavudine, those are the D drugs. They're really bad side effect profile. So in terms of the non-nukes, remember, the non-nukes are not a nucleoside or nucleotide. So you can remember a little bit, the non-nukes have a little bit of a more side effect profile that's a little bit generalized. The most important one in this category is efavirenz, the EFV, also called Sustiva. And when you combine efavirenz with tenofovir and emtricitabine, you get a triplet, right? So your TDF-FTC-EFV gets you your triplet, and that's a nice way to kind of mind map it to bring it together. The second way of remembering for your non-nukes is rilpivirine, which is a fabulous drug, RPV or Indurant. This has also been very effective, and when you combine rilpivirine with our favorite backbone, Truvada, you get Complera, which is the brand name. You also see etravirine out there, ETR and Telens, and then nevirapine, NVP or Veramune. Those do not have any fixed dose combinations, but they are your helpful friends when you start getting resistance. Integrase inhibitors, one of my favorite classes to use because resistance is low for those, and they are a lifesaver for not only your naive but your experienced patient. Raltegravir is the old standard. RAL, Icentris, that's a twice-a-day dosing, and elvitegravir, EVG, plus its booster colbicistat, that is in a fixed-dose combination. And then dolutegravir is once a day, DTG, Tivicay, once a day. If you have resistance, you give it twice a day, but you can see now the elvitegravir and the Truvada, again our favorite backbone, becomes Stribold, which is the brand name. And now we have a fixed dose with dolutegravir called Triumeq. So combining your Epsicom with your Tivicay, if you will, you get your Triumeq. So remember it, your abacavir, lamivudine, and dolutegravir is your Triumeq fixed dose combination. Now PIs, your protease inhibitors, you'll see darunavir, DVR, is Persista, plus ritonavir and norvir. And the way that you say this is it's boosted darunavir. So you're boosting darunavir with ritonavir. So you'll see it written DVR/r, and that's all that's saying is that we're using the ritonavir to boost the darunavir so that we don't need such high doses of darunavir. So we reduce the side effect profile. Same idea at atazanavir, ATV, which is also called Rayataz, plus or minus ritonavir. We like to give it ritonavir if people don't tolerate it. You don't need to. And then fosamprenavir, FPV, Lexiva, plus ritonavir, and Calitra with ritonavir, which is the leponavir. I'm sorry. The fosamprenavir is Lexiva, leponavir is the Calitra, and I'm sorry for the format problems. It's a Mac to PC thing. Don't worry about these PIs. We do not see them. If you're working in developing countries, you might see them. Saquinavir, Indavir, nalfenavir, and tapranavir. Those are historic significance, and you don't need to worry about those. Your CCR5 antagonist, this is really for patients who have severe resistance, is Maraviroc, MVC cells entry, and fusion inhibitors and furatide. So moving on, this is the way of looking at it just with the abbreviations. So these are the recommended regimens, and these are the ones we just went over. So remember, your efavirenz, tenofovir, emtricitabine is your tripla. Your PI-based regimen is your atazanavir plus your Truvada, and your darunavir plus your Truvada, and your integrase inhibitors. So your dolutegravir plus your Truvada, dolutegravir plus your epsicom combination, ABC3TC, your Stribold, your alvategravir, and your raltegravir regimen. So HIV Pearl dolutegravir is actually superior to efavirenz and darunavir when used with a NRTI backbone, and your HIV Pearl number 2 is that you can actually interchange 3TC with FTC, so lamivudine and emtricitabine. So yes, you can have other recommended regimens. Won't dwell on them too much, but these are when your initial HIV viral load is less than 100,000 copies. You can use a rilpivirine-based, which is your Complera, or your efavirenz with your bacavir and your lamivudine. You can also substitute an atazanavir with your epsicom combination here. And for pregnancy, still recommended leponavir plus zidovudine and lamivudine, which is your combivir therapy, very well known for pregnancy. In pregnancy world, we like to use zidovudine because it has the most efficacy that we've demonstrated. ART, initial alternative regimens, won't dwell on this, but suffice it to say you can combine your PIs with other ways of using a nuke backbone, and same with your integrase inhibitor. So there you have it. That's the long view of it. So going over your nukes, if you will, the advantages, as you see, it is the backbone of therapy. So whether you're using the TDF-FTC or ABC3TC, those are really your mainstays. Minimal drug interactions. Certainly tenofovir has problems with renal function. Your disadvantages, you do have to worry about renal function. So if people are on hydrochlorothiazide or diuretics, sometimes you have to adjust that and really be careful with it. We do not see a lot of hepatic steatosis or lactic acidosis because we're not using those D drugs anymore, so would not worry about it. In terms of your non-nukes, these are also very helpful. They're longer half-lives, and they're helpful in terms of combining with your nukes. However, you'll see with efavirenz, which is a non-nuke, you have a very low genetic barrier resistance. In fact, that's the most, the most frequent barrier that we've seen, the most frequent mutation that we've seen is with efavirenz, which is a non-nuke. You can get rash, and efavirenz you can get mental health problems, actually. You can get nightmares and CNS effects. Protease inhibitors, very good because it's very difficult to get genetic mutations in your virus, however, sometimes it's a higher pill burden because they're taking ritonavir with it. People have asked me, why can't you just put ritonavir with the PI, and it certainly makes a lot of sense, but for a lot of reasons it's not done, but certainly the Kaletra does that, but we need to certainly work on a better way of getting the pill burden down. Integrase inhibitors, now we have a once daily dosing. We actually have it in 2 combination pills. We see it's incredibly effective. It has a little bit lower genetic barrier resistance and some other side effects you see there, but really not terrible. And the CCR5, rare to have someone on it, but it does do well. It does have a good virological response. It does have few adverse effects. It's hard to get it paid for by insurance, but once you demonstrate that there's a lot of resistance, it works pretty well. Be sure that you remember your tropism. It has to be a CCR5 tropism to use, and make sure you don't have a mixed tropism. So what are the side effects? The biggest thing you need to remember is abacavir, and the company that makes abacavir is actually paying for this test for free because it's that important to make sure that your patient doesn't get a hypersensitivity reaction. So always test for it. We like to test sometimes in the beginning of a patient's course, but certainly make sure that you test for it if you're thinking about using an abacavir-based regimen. And remember, this is abacavir by itself or in the combination ABC3TC, which is your epsicom. Also important effects, your tenofovir does cause rhythm impairment and decrease in bone mineral density. Sometimes I put my patients on calcium supplements or multivitamins. We're coming out with a new one, TAF, which is a tenofovir-based regimen with a different subset, so that hopefully will decrease osteopenia and osteoporosis in the future. And also zidovudine can cause headache and lymphoatrophy. Remember, a neat kind of side effect with zidovudine is that you'll notice an increase in their MCV, which is their mean corpuscle volume of their hemoglobin, which in the old days we used to look at and see increased, meaning that patients were actually taking the medication. But you'll see that as an increased MCV on your CBC. Adverse effects of your non-nukes, definitely a rash, hepatotoxicity, and certainly more drug-drug interactions. And I would add to that mental health or bad dreams. As you can see here, neuropsychiatric complications with the Fabry. Rilpivirine is associated with depression, and we should not use it if there's a high HIV RNA, and there are higher rates of virological failure when your baseline CD4 count is less than 200. So reserve your Complera, please, for patients with a lower viral load and a higher CD4 count. NRTIs notoriously cause lipodystrophy, meaning that you can have a posterior neck cervical adiposity or fat pad. You can also have GI intolerance. Also look for increasing cholesterol in these folks. Very important if they have other cardiovascular diseases or familial cholesterol problems. Probably less of a choice for those populations. Adverse effects with your integrase inhibitors. I have to say, I have not seen one bad effect yet. It can cause yellowing of the eyes. That's the only thing we might have seen once, but otherwise, I have not seen it. But in the literature, we see that it can increase your serum creatinine. It can cause myopathy and rash, but I have to say these are incredibly well tolerated. Dolutegravir is probably the least side effect profile. Maybe a little bit of headache or insomnia, but I have seen it very well tolerated. Maraviroc, rash, liver problems, but I have yet to see a problem with this. Other assessments, remember your HLA-B 5701 screening for your abacavir. Easy to do, just check the box on Quest and LabCorp and you're all set. Co-receptive tropism is a special test, and just remember people can change their tropism if they've had HIV for a while, but in a new infection, you should be able to get an idea. We don't really send this off in a new infection. We try to put them on the other medications first. So ART adherence, I think the take-home point of this is knowing that HIV is a treatable and chronic disease, but treatable in that we thankfully are removing the stigma of having HIV and also removing the stigma with behaviors associated with HIV historically. So I think we're making a lot of progress, and with a robust social network, I think we can definitely address these factors that you see. One thing I'd like to bring up for case managers in particular, we've noticed a trend with young people. It's sometimes hard for folks to carry around pills, especially when traveling or visiting family. And so we've noticed that there are very creative pill cases out there. Some of them just look like necklace charms and different things. So I would definitely kind of talk to your patients who are having difficulty with their meds and kind of understand the reason for that. And making kind of creative options that people can either disclose their status or basically feel comfortable taking their medications when they're traveling or on the move. Improving adherence, support and reinforcement certainly, simplifying the dosing. Reminders, there are some apps now. That's actually, there's something called Care for Today, which you can use too, and that is good for your tech-savvy patients. And then really creating that patient-provider rapport to see what works for your particular patient population. Now with ART resistance, just briefly, we're seeing about a 6 to 16% transmitted drug resistance rate in the United States. It's higher and lower in other parts of the world. depending on the availability of ART. In the southeast United States, where we are specifically, we're seeing about a 9.3% transmitted drug rate. This is out of the North Carolina AIDS Research HIV Clinical Cohort. This had about 700 plus patients that were analyzed, and what we're seeing is that K103N is really the biggest mutation. That's your efavirenz. You're also seeing some L90Ms, which are PIs, and D67N, which is actually your ADT. So we're not, thankfully, in the South seeing a lot of bad resistance. We're getting there, but in terms of transmitted resistance, we're still able to use our integrase inhibitors. But interestingly, 21% of acutely infected patients had a transmitted drug resistance, so one of these. So moving on briefly, so basically remember to check for your resistance testing, and a big take-home point, please recheck your viral load at least 2 to 8 weeks after dishing ART. We check 2 to 4 weeks. You really have to make sure you're suppressing your genome. If you're able to suppress your genome in the first few weeks with your regimen, then you're really in a good stead. But if you let the virus be partially treated, you're going to really have a lot of problems down the line. And remember, if someone's been off of your ART for more than 4 weeks, it's going to revert to something called a wild type, which means that you're not going to be able to see the resistance mutations. So please get your genome when someone's newly diagnosed, start them on therapy, check them in 2 to 4 weeks, and then hopefully they'll be suppressed. 184V, just an important point. This actually infers resistance to 3TC, ABC, and FTC. Why that's important is that we try not to use these combination pills when we see them as combinations. Now, an exception is when someone has hepatitis B that we need to suppress, but generally speaking, these folks will have improved sensitivity to AZT and TDF. What to do about hepatitis B? I know everyone is checking their patients who are newly diagnosed with HIV for hepatitis A, B, and C. Take-home point here is that if your hepatitis B surface antigen is positive, a really good idea to get a hepatitis B viral load, because that is saying that the body has not had any immunity yet. However, you do not need to check a viral load if the antibody is positive, means that there's immunity, or if they're already on a suppressive regimen, and that would be your Truvada, your TDF-FTC regimen, and even your lamivudine in there as well. That will suppress your hepatitis B. Remember, a hepatitis B core antibody by itself usually means prior infection, and that we're not able to see immunity because the immune system is weak. So I would still put them on a suppressive regimen and would still actually give the vaccine. This is a common management question. Yes, please give them 3 shots. I would suggest not the Twinrix, which is a combination AB shot, but the actual Hep B vaccine. The reason is the Twinrix Hep A, Hep B vaccine has a combination antigen in that, and it actually is at a lower concentration, and we've actually had patients not mount immunity to the Twinrix as they could have with the higher antigen load with the Hep B series by itself. So Hep B core, and then please do Hep B vaccine. And then also, these are the drugs that will suppress your Hep B. Remember, this is super important because when you're changing regimen, always make sure that you know their hepatitis B status, because if you're changing from a medicine that's suppressing their Hep B to one that is not, you can actually have a fulminant resurgence of hepatitis B. So remember, suppress your Hep B if they're positive core or antigen, and that's a tenofovir, FTC, tenofovir, and lamivudine, and also entecavir if you can add it if they're not being suppressed, or if you need to change the regimen out of the nuke regimen. So moving towards the end, ART is for everyone. If we think that someone's going to have trouble, it means we have more work to do to get them plugged into care. And then there's fewer barriers such as side effects or access in this modern age. So we're very lucky and fortunate for that. Patients do know to commit to lifelong treatment. It's always good to benefit, and benefits are very long in terms of longer life and less morbidity. Here are the guidelines website, and thank you very much. I'll be happy to take any questions.
Thank you so much, Dr. Morano, for that excellent update. So we will go ahead and get started with a few questions. So one question, Dr. Morano, is how long after ART initiation should we expect to see a patient with a fully suppressed viral load?
Sure. Great question. Part of this has to do with how high your viral load and how low your CD4 count is at diagnosis. But for a newly diagnosed patient, we actually see suppressive, probably, I would give it about 3 to 4 weeks. 4 weeks we would expect the viral load to be fully suppressive. In Connecticut, where I trained, we would actually check viral load at 2 weeks to make sure that we were suppressing the virus. So in areas of high viral resistance, we would take a genotype at the first first diagnosis. We take a genotype. We'd put on a regimen based on these guidelines. We'd recheck a viral load in 2 weeks, make sure it's coming down, and we'd expect a fully suppressed viral load of about 4 weeks. The longest would be 8 weeks. If I can just add something else, if the viral load is not suppressing, I'd recommend rechecking the genotype. So let's say you've been working with the patient for 1 or 2 months, it's not suppressing. We can actually get genotypes at the 400 copies per milliliter level. A lot of labs will only do the 2,000 copies per milliliter level, but some will do the 400, which is very helpful.
Thank you. So another question is if you have a patient who is transferred to your care and they're already on a fully suppressive antiretroviral regimen, how do you handle the issue of the recommendation that patients should have a baseline genotype upon entry into care?
Right. So the good news is that you don't need to worry about it. So ideally, when we're newly diagnosing folks with HIV and they have a detectable viral load, we're taking that genotype right at that moment. Now, something creative that you can do is when a patient comes in your clinic with acute HIV and needs treatment, what I do sometimes is take a genotype and actually start my best guess treatment then, and then I can modify it based on the genotype. Because remember, the genotype takes 2 weeks to come back. So to answer the question fully, if someone's coming from another center, they're already suppressed, the good news is you can kind of take a deep breath, and you don't need to worry about getting a genotype at that moment because you're not going to be able to get one, right? You don't have any virions to send for a genotype. It's always helpful to be very proactive in getting the patient's old records, however. So where I am at the Department of Health in Hillsborough, we have a very active medical records department, so we're always asking for previous genotypes so we can get those facts to us and put in their folder. The reason why that's important is that we understand then what their genotype might be. Then in the future, if your patient has problems and we're seeing virus, we can always retake that genotype. If I may add, it's a good idea. Let's say you have a patient that is coming to your clinic already suppressed on a regimen, and they develop a detectable viral load. I would continue that medicine until you have a genotype, remember, because once you take them off an ART regimen, their virus will revert to wild type, and you'll not be able to find those resistance mutations anymore.
And along those lines, with some of the tests we get at baseline, the HLA-B5701 test you mentioned is something that we would want to obtain before starting a patient on abacavir. And what if you had a patient who's been on an abacavir-containing regimen for quite some time and they transfer care to your clinic? Do you obtain the HLA-B5701 even though they've been on that medication?
Sure. I think the answer to that is yes. You should have one on file. I think you can also breathe a sigh of relief. It's very rare for someone to develop acute hepatotoxicity and rash on abacavir if they've been on it for a long time. Let's say someone's been on it for 3 years. Chances are they're HLA-B5701 negative. For housekeeping, certainly you can run it to make sure. But usually these abacavir-associated hypersensitive reactions will happen within, I would give it about 3 to 4 to 5 days. And so usually you'll know about it. But yeah, I think it makes sense in terms of guidelines. Usually if they're on it, let them be on it. But usually you'll know that they have a reaction before then, for sure. Something I just want to add, something about re-challenging with the Bacavir. Before we had a robust test, we would have someone on a Bacavir, they'd have a rash, and then sometimes in a how do I say it, in a not so good scenario, someone would be re-challenged with a Bacavir, and that could actually, as you can imagine, is even a worse reaction. So yes, I would definitely, check, especially when you're starting it. If they're already on it, chances are they're safe, but I would just check to make sure, but rare to have a hypersensitive reaction that late.
Yeah, I would agree. A lot of times we would not do the test if someone's already been on the medication for quite some time, but now that it is a more readily available test and inexpensive, I think just to kind of cover the bases and document that they don't have that HLA test and to document that as being negative. A lot of times that test is ordered, but like you said, probably not likely that they would have any possibility of having that reaction.
Right. And I'd encourage folks working in the departments of health or clinics to talk about how to get that test actually fully paid for you. So I think that the company, I don't know what company it is, but they will work with your health department to get that free for you.
Thank you. And can you summarize real quickly what the main difference is that you've seen with the 2014 guidelines compared to the 2013 guidelines?
Sure. So the 2014 guidelines, I think the take-home point is dolutegravir, the integrase inhibitor, was really the game changer here. It's a once-a-day integrase inhibitor, and it's now in two one pill a day formulations. So that's certainly important. Also, the second major important fact of the 2014 guidelines is actually the addition of the co-infection guidelines with hepatitis C.
Thank you. And another question that came in is, how do you handle patients that have active alcohol or drug use in your practice? Do you basically defer antiretroviral therapy when you encounter that situation?
Right, so there's a lot of interesting thought about this. So traditionally, folks have thought, well, they're going to be non-adherent. Why are we, giving them ART if they're not going to be adherent? Well, there's actually some literature that came out of the Northeast where there's a lot of IDU, and they found that, believe it or not, heroin users for some reason actually can adhere to ART. And there was actually a mobile clinic study up in New Haven that showed that we can give antiretroviral therapy. It's called directly observed antiretroviral therapy, which was popular for a while. So the take-home message for that is get them into care, have a conversation with them. There are very, very good drug and alcohol treatment centers and programs out there. It is a challenge, yes. Technically, it should not be a barrier to starting ART. There are, unfortunately, many people who can do drugs and alcohol and still keep up with their ART. So the way that I handle it in my practice and the literature is that it should not be a barrier to ART. There's naltrexone, which is a IM injection for alcohol use, which works very, very well. And there are a lot of good referral centers. Opioid replacement, such as buprenorphine, has shown very good efficacy for folks who are using opioids or heroin. We've seen some cases of IV methamphetamine currently that, obviously would complicate things, but that was in more of a pediatric population. We were able to make the appropriate referral to pediatric counseling service, and that actually resolved. So I guess, yes, it just takes a little bit more time in terms of coordination, but I would not treat it as a large barrier. It's just something to kind of work through and to talk with the patient about. They might actually be motivated to stop their substance use if they know that they can get therapy.
The Florida Caribbean AIDS Education and Training Center's mission is to ensure that physicians, nurses, nurse practitioners, physician assistants, dentists, pharmacists, case managers, and other healthcare professionals in Florida, Puerto Rico, and the U.S. Virgin Islands receive state-of-the-art information, training, and consultation on the prevention, chronic disease management, and treatment of HIV and AIDS. Funding is provided by the HIV/AIDS Bureau of the Health Resources Services Administration, U.S. Department of Health and Human Services. The Florida Caribbean AIDS Education and Training Center provides a variety of HIV/AIDS education, training, consultation, and resources. Visit our website, www.fcaetc.org, to learn more. Stay in touch with us by joining our mailing and email list. You will receive notices about upcoming educational opportunities as well as new and updated HIV/AIDS resources. You may also sign up to receive our HIV CareLink newsletter. Visit our website, fcaetc.org, and click on Join Our Mailing and Email List at the top of the homepage. Be sure to also connect with us on Facebook, Twitter, LinkedIn, and YouTube. The Florida Caribbean AETC provides consultation services to clinicians in Florida, Puerto Rico, and the U.S. Virgin Islands. If you have questions related to the content of this program or would like consultation on the diagnosis, prevention, and treatment of HIV/AIDS and related conditions, we would love to hear from you. We also offer consultation on the interpretation of resistance test results. Visit www.fcaetc.org/consultation to ask your question today. The Florida Caribbean AIDS Education and Training Center provides pocket-sized treatment guideline resources that detail the federally approved HIV/AIDS medical practice guidelines, such as the adult antiretroviral therapy, hepatitis, pediatric antiretroviral therapy, adult opportunistic infections, tuberculosis, and pre-exposure prophylaxis, non-occupational post-exposure prophylaxis, and occupational PEP. In addition, we have summarized common practices for the post-exposure prophylaxis in pediatrics adolescents. We have also developed resources that provide an overview for treatment of sexually transmitted diseases in HIV-infected patients and therapeutic agents for oral manifestations. Visit our website to download or request copies of these resources. The Florida Caribbean AIDS Education and Training Center provides web-based educational opportunities to increase the knowledge and skills of HIV healthcare providers. Live and on-demand options are available. Visit www.fcaetc.org/education for more information. Florida Caribbean AIDS Education and Training Center, Project ECHO, provides a web-based didactic presentation on a current HIV treatment issue based upon current Department of Health and Human Services and other accepted treatment guidelines. Project ECHO also provides an opportunity to discuss case presentations submitted by participants and an opportunity to network with both your peers and HIV experts. All members of care and treatment teams, including case managers, are welcome to participate. Information discussed is targeted at providers with basic or intermediate HIV/AIDS treatment experience. Choose from 4 session types. Visit www.fcaetc.org/echo to view upcoming sessions and to register. If you're located outside of our region, the Clinician Consultation Center provides consultation services via the phone numbers listed here. Or you may also visit www.nccc.ucsf.edu for more information. To locate the AETC in your region, visit www.aidsetc.org.